So we will pass to Dr. Jean-Baptiste Roche, a great friend of mine from our residency in France. So thank you for coming in Thessaloniki, and he will talk about thulium laser enucleation, ThuLEP.
Okay, so first, thank you. Thank you for your welcome. Thank you for your kindness. Thank you for all this friendship we have for years. And I'm very, very happy to be here. It's a real pleasure to discuss about surgical techniques. And I hope it's going to be okay. I had the work to try to defend or to promote thulium surgery. So I will begin on that to try to describe this laser, to try to describe my way I use this laser and how I began with this laser, despite the fact that it was in an holmium wave at the beginning of enucleation. But I still think that there is a place for this laser, and so I would like to expose it to you. So first, I have to say that the first thulium I began with was a Revolix in 2012. The first paper published was coming from Germany because it's a German laser from Lisa Laser. And the first result was pretty good with probably quite small prostate, but with excellent results in terms in PSS and voiding results, with reduction of catheterizing time and hospitalization stay when you compare it to TRP, with a number of urinary infection, irritative symptoms, but it was a quite interesting technique. And the story of thulium began with the German guys. So I have to say that the wavelengths of the thulium is quite close to this one of the holmium. The energy is going into the water, so that's the reason why I think it's a quite safety laser, because there is no deep coagulation of the tissue. And so it's an interesting laser to work with. And as you can see on that slide, the diffusion of the energy is very superficial and probably the most superficial of all the laser on the market. It's just 1.2 millimeters. So interesting tool to work with. So thulium has laser specificities. It's possible to do enucleation, of course, and we're going to discuss and talk about that, but it's still possible to do vaporization, vaporesection, and vapoenucleation of the prostate with this laser. So these principles have been described by the Torsten Bach from Hamburg. And so you can see that the vaporization is a destruction of the adenoma tissue. The vaporesection is the resection of small ships of tissue, and they began like that. And then after, you can wash the different ships of prostate to remove this tissue. And then and it was before any morcellation system. The vapoenucleation is the way to go to enucleation, with a combination with the vaporization of the median lobe and the lateral lobes, using at the end the morcellator. And then after, of course, the thulium enucleation with the Blum enucleation with laser support. So just a word of vaporization. It's a good technique, especially for patients who have small prostate and prostates with anticoagulation drugs. It's quite nice to have this technique, and I will show a small movie on that, because you can use it without any morcellator, and it's totally possible to use it with patients with anticoagulation drugs. And I sometimes still use it, because if you have an old patient with a small prostate and it's difficult to stop anticoagulation drugs, you can perfectly do this vaporization. And it's not mandatory to have a morcellator to use it, only a cystoscope or a resectoscope and the laser. So I have to admit that I began with that because at the beginning I was doing some green light. I moved to the thulium, and I will tell you why. And I began with that technique because I had no morcellator. It was too expensive for the institution. And so we began like that with quite smart results, even if probably we have irritative symptoms more than with blunt enucleation during this procedure. So as you can see, and I want you to show this, the charring of the thulium. So it was the first generation of thulium we used to vaporization up to 200 watts. And if it's charring, it's nice because it's very good hemostasis. And you have to know that with the thulium, when you use it in a continuous wave and continuous emission, you have a very interesting hemostasis. And generally, the patient like this is one-day surgery. And so it's very cost effective. And you can use it with reusable fibers. And so it's possible to do 20 cases with that time. And I use it for my learning curve because it was interesting to use it very safely and have the first steps to manage the resectoscope, as you can see, because the movement of the surgeons with the hands are very different when you use a laser, when you compare it to ThuLEP. And it was sometimes I used to make the learning curve easier. So as you can see, you can cut the different lobes, and then you can use vaporization of the tissue with a quite good anatomical results and absolutely almost no bleeding. So that's the first technique you can use with a thulium laser. So the second technique, the second technique is the vaporization of prostate. So it was my second initial experience with the thulium laser. It involves the resection of piece of prostate, and it's not mandatory to be in the plane. And you can switch from this experience not to be in the plane to try to find the good plane, the perfect plane of enucleation, but it's not very easy at the beginning. And that's the reason why I think for beginner with the thulium, it's an excellent technique for smile and mad prostate to begin your laser experience. Of course, you have to limit, of course, you have to limit the size of the prostate you're going to treat. But with that, and with an initial experience of the morcellator with small volumes of morcellation, it's quite nice to begin, because the beginning of enucleation can be quite difficult, as we discussed before. So you will see it's when you use vapoenucleation technique, generally you use a 4-lobe or 2-lobe technique because it's not mandatory to be in the plane. And then after, you're going to have an anatomic dissection of the prostate outside of the plane. And I have to say that I still use this technique when I have anticoagulation and when it's difficult to stop it, because I saw that the risk of scar drop after this kind of technique is probably reduced when I compare it to blunt enucleation. So like this, you go step by step from vaporization, and then to go to a technique approaching real enucleation of the prostate. So the problem in the technique, and that's the reason why the thulium was not very recommended at the beginning of enucleation, is that you have this charring. So as you can see, there is very good hemostasis, but it will be very difficult to find the correct plane of dissection when you use that kind of charring, because it's troubling the plane of enucleation. So as you can see, you manage the dissection, not in the plane, but going slowly, with time, with experience, with patience, in the correct plane. And with that, I have to say that there is no big mistake or big troubles with the patient during your first 50 initial case to have a good learning curve. And what is interesting with the thulium is that because it's a very superficial laser, you're gonna have, of course, irritative symptom because of the charring, but generally not more than 2 or 3 weeks because it's very superficial. So the secretization is quite quick. So I think this is not a bad way to begin your experience with the thulium and to switch to enucleation. So what are the results of this technique? It has been published more than 10 years ago, and the results were quite good. So if you can see this trial, you see that of course the post-op volume was mine. It was 50 grams. The catheterization times was quite short. It was less than 24 hours medium, and the duration of hospitalization was generally 1 day. The PSA drop was not perfect, but it was reduced by 2. And if you see the results at 1 year, the Qmax was quite good, and the APSS was quite good too at 9 months. So interesting technique, quite easy technique to learn, and a good way to begin your experience with the thulium laser. And then after, we go to the enucleation of the prostate with the thulium. So I would like to discuss with you and expose the way I came from this vaporization to enucleation. So it began with Fernando with an amazing trip in Bulgaria. It was a really great moment. Vincent was here. And what we saw at this moment with the technique of Fernando was a real change in management of prostatic adenoma, and it's something that marks us for years, and that's the reason why we decide to move from vaporization, green light or thulium to the enucleation at the beginning of the 2010. And so what was the aim of this travel and this experience? Of course, to improve the postoperative results, immediate postoperative results, and voiding results. And of course, reduce the risk of recurrence as we can have during vaporization or non-enucleation technique. But the problem that I had some constraints. I had to adapt my laser to the resectoscope, so I have to change my device. I have to be cost efficient, and as I told you, it was not possible at the beginning to buy or to purchase a morcellator. It was too expensive. And to keep the ability to perform vaporization and reduce the learning curve, because at the moment I was a beginner. So I had to take all these things in the pack and try to see the good way I can go to the objective to enucleation. But I also desires, for me, it was probably an opportunity to develop innovation with industry and create a partnership with industries, which is always for a urologist something very interesting, I think, to discuss with engineers and go a little bit more in industry business, and then try to move what the German guys was doing at this moment, which was ThuLEP and vaporization with the thulium, to a real anatomic enucleation with the thulium. So for that, I decided to, with the engineers of Quanta System, we decided to switch the continuous wave mode of the thulium to go to pulse mode to try to have the ability of dissection comparing with the ability of cutting, and try to have a Moses effect with the mechanical effect to try to open a little bit more the plant, because at the beginning, the enucleation with the thulium was generally cutting like we do in vapor enucleation, close to the plant, but not in the plant. And so that's the reason why we discuss with Rocamed and Quanta System to try to move the Cyber TM 200 watts laser to an evolution of the MRA system of Rocamed with the ability to change the settings and change the emission mode of the thulium, the typical thulium, the basic thulium, to another thing. And that's, I think, a very interesting project to cross my experience with the experience of the industry, and I recommend it to try to work with the industry and not against the industry. And so now there is a new evolution of this laser, because now it's a TFL, it's kind of rising up. We know it for the stones, but we try to find a good way to optimize the settings and the way to use it for BPH. So this thulium fiber was developed by Oliver Traxler for the stone with pump job modules which activate a laser fiber and deliver a very impressive Moses effect with this system of thulium. It's almost a small wavelength, honestly. It's the same characteristic on the tissue, but what is going different is the frequency of the pulse that you can have, and it's so useful for the stones. So as you can see, there is difference between, and it's at the worst part of the screen. With the TFL, you can rise up your frequency to 2020 hertz. And what is quite different with the holmium is that with the holmium, you have a great peak power, all right? And you deliver the energy in a very short time. And with the TFL, you can change the time of emission and to have more coagulating and hemostatic way to manage the laser. So you can change the pulse duration and the pulse profile when you adapt the setups of the thulium fiber laser. What is interesting is that it's not single use. You have single use for the stones, but you can use it with reusable fibers, and it's very interesting for the costs. So we have two thulium fiber laser on the market. One, sorry for the slide, because I had a problem with the PowerPoint, but to be honest, there is one serious Quanta Rocamed system and one Solstice system. The difference is probably the power. The Olympus is a 100 watt power, and it's a 60 watts for the Quanta Rocamed system. But they are both very, very efficient. So for the enucleation technique, my initial surgical management was the 2 or 3 lobe technique. I think it's not a bad technique. Of course, you will have to move from this to apical release first and en bloc technique, but it was the beginning of my experience, and I have to copy that from the initial description of Peter Gilling. And now, of course, as Fernando showed you, we use an early apical release and an en bloc dissection. So I would like to show you, because tomorrow we're going to have a live with the 200 watt MRA laser. That's what we have. I would like to show you a short video about the serious technique and the TFL, because tomorrow you're going to see the intermittent, the pulse standard cyber thulium 200 watts. So it's quite a recent video. So what is very interesting with the fiber thulium is that you have plenty of settings. You can do what you want. You can do you can change the duration of the pulse, so small, medium, or long. You can change the frequency of the system, and of course you can see all the power. And I think that we're going to have to work on that. We're going to have to see what are the results of the different settings, because I think that they are very, very different in the way you manage these settings. You're going to have very different effects. So I try to use a long pulse, a low frequency, and almost at 33 watts. And as you see, I would like to have the same Moses effect. It's not the same, of course, because the peak power is lowest, but try to have a good Moses effect, because I think that with the time, what's going to be very important for the results will be try to not to touch the prostate. At the beginning of the experience, I had to dissect a lot with the resectoscope, and I think that when you do that, you're gonna probably pull on the different anatomic structures, especially on the sphincter, but on the capsule too. And I think that the less you touch the adenoma, the best you are for your result, because you're going to reduce the small damage of the capsule that can create, I think, irritative symptoms post-operatively. And of course, if you tract less your sphincter, we know that from radical prostatectomy, you're probably going to have better results for the continence after the surgery. So as you can see, I think that at the moment with the settings I have, it's a mixed technique between enucleation and blunt dissection and laser emission. So as you can see, you can find again the charring of the thulium laser, but we try to reduce it with the sphincter, with the settings, to try to see perfectly well the plan. So where the thulium is very interesting is the hemostasis. As you can see, it did almost nothing. What is more difficult for enucleation is the reduction of the Moses effect because of the duration of the pulse. What we know now from the guidelines is that what is very important is to do enucleation and anatomical enucleation. We know that, of course, we're going to have slight difference between the different tools you're gonna have. I think that I have no experience with the very recent holmium lasers, but at the moment, for me, there is no absolutely perfect system on the market, because if we had one, we should probably have all the same. So we're going to have some improvements with the thulium, I think, for hemostasis and perhaps irritative symptoms, but probably that the enucleation is a little bit more difficult because of, and so the during time of enucleation will be a little bit longer when I compare it to the holmium. So it's a mix, I think, between blunt enucleation and holmium technique with no touch. But as you can see, it works well. The settings will be very important to work on. As Fernando, I have to say that it's very important when you do your enucleation is to be very close to the adenoma. You have to detach the adenoma from the capsule and not the contrary. So you will see the effect between the MRA system and the Saltive or the serious system with TFL is not so different, for me, in my experience. When I use one, I use it almost the same that I was using the previous one. Perhaps I will quit this because it's a little bit long. So you can see the thermal effect. So new generation of thulium. So I will expose some results. So I don't want to be too long. So I just took this recent paper about meta-analysis comparing thulium laser and holmium laser for benign prostatic hyperplasia, and the results of the thulium are quite interesting, because you can see that operation time seems to be better with the thulium. Morcellation times is the same. Catheterization times is probably the same. Hemoglobin decrease will be in favor of the holmium system. But when you compare the results at 3 months, there is better EPSS and same quality of life. What I think, because of this EPSS, is probably that because it's a very superficial wavelengths delivered in the tissue, the cicatrization after thulium is quite good. And generally, when I see the patient at 6 weeks, they don't have any irritative symptoms anymore. So I think it's an interesting laser for that. And it's in the physical characteristic of the laser. It's not a big surprise. And when you see at 12 months the results, we have to say that it's probably comparable between the holmium laser and the thulium laser. So thulium is a safe and efficacious alternative to ThuLEP and TURP. It's non-inferior, I think, and for some outcomes, but you know, papers, it's always the way you want to present it. But it seems to be better for EPSS at 3, 6, 12 months and 24 months. And thulium fiber laser have the advantage to be high frequency with less degradation and less energy consumption. So it makes for that quite cost effective and operational. So I won't talk about the guidelines because Professor Stavros did it perfectly. I just want to say that no problem with the thulium. It's recommended in all the case of prostate for vaporization, for vaporesection or enucleation in all that kind of patients. So it's like a swift knife of surgery for BPH and working with stones too. So I think it's quite cost effective and exciting tool to use. Thank you.
Dear Jean-Baptiste, thank you very much for this excellent presentation. I will start with 1 or 2 questions, and then I will address for people watching us and online users that are not asking a lot of questions. I have to see that. So we know, everybody knows that you are a world-class robotic surgeon, and you are doing also BPH. Do you find that doing BPH is boring? Do you prefer robotics, or it's how do you feel about that?
So you know what, that effectively robotic surgery is a patient for me, and I'm from a very important robotic team. But it was my business in the team to try to develop laser technique in Saint Augustin, and I have to say that it was a difficult way to go, but it's an amazing way to go, because when I began the surgery with vaporization, I think it was not a surgical technique, and that's one of the reasons I had to move to enucleation. And endoscopic enucleation is a real surgery. It's endoscopic and minimal surgery and minimal invasive surgery, but it's a real surgery. It's a real dissection, exposition of the plane, using tools, have a real you need to really know the endoscopic anatomy. So it's absolutely not boring. And add all the very interesting technique like robotic technique. It's we have an evolution of the endoscopic enucleation all the time. And I think it's one of the reasons why it's a great technique. Because like in robotics or laparoscopy, this surgical technique has an evolution. And for me, it's one of the proofs that it's a technique very interesting to develop and probably a rock, a rock in urology, especially for the treatment of BPH. And to be honest, I was doing at the beginning vaporization, then after enucleation for small prostate and robotic surgery for big prostate, or laparoscopy for big prostate because it was too long for me. And I have to say that now I've switched all my BPH activity to endoscopic enucleation technique. So I stopped probably robotic simple prostatectomy, because when you see the results for 250 grams of prostate and the patient is discharged the day after, and I think when you have a good anatomic experience, there is almost no incontinence after that kind of technique. I have to say that for me, for the recent years, it's absolutely no boring, because I convert all my BPH activity to laser enucleation.
Okay, and I see that you are using the Kunz element that we use normally for mechanical.
Yeah.
Do you think that the irritative symptoms are because of traction or because of the amount of energy applied on the tissues?
I think both. I think that energy you deliver, especially with the laser or bipolar enucleation, irritative symptoms you create, because you're going to have an inflammation of the prostatic area after when you do the sacralization. But I think that when you do a blunt enucleation with the cystoscope, you're going to create some small damage of the capsule, and this small damage will have to cicatrize after and probably create the irritative symptoms in the first 3 or 6 months. Because with time, there is no problem with the cicatrization. You have to know that to have an epithelialization of your prostatic area, you need between 3 or 6 months. So the less damage, traumatic damage you create, the less energetic damage you create, probably the less irritative symptom you're going to have. So if you improve your dissection, and if you manage well and more your laser, probably you're going to reduce the irritative symptoms you have after endoscopic enucleation.
Okay, thank you very much. Any questions, please?
Okay, so I would like to make a comment then. I know that this session is all about enucleation, and about the vaporization, there is a stigma that says that this is not a real operation, okay, and there is no place for that. I think that there is a place for vaporization, and I explain my thesis. And all this stigma is because of the aggressive marketing that had received the vaporization in the past years, and the bad results that came from that. But there is a specific subgroup. I have a couple of patients that I have operated with many years ago for urethral strictures, and they have urethroplasties. And some of them do not have the perfect urethroplasty because it was operated for me. So it's a bit, the caliber of the urethra is not the optimal. And I would be real grateful if I had a way to perform a BPH treatment with a smaller caliber endoscope. And the only way to do that is with vaporization. So it's not something that has no place. sometimes it's the only way.
Yes, I have to say that the instruments now are going to smaller and smaller and smaller. There is a colleague from Argentina, if I'm not wrong, Fernando, that is doing a slim ThuLEP or ultra slim and Brazil. Yes, and it's 18.5 French of endoscope, so it's progressing.
The problem is not the endoscope. You can do resection with a small endoscope. The problem is the
Oscillation.
mucilation, yes.
Yes, but
So you have to.
22 French.
Oh, I didn't know that.
Yeah, it's getting more and more visible.
please. The micro, please, for the online colleagues. Yes.
Okay, I'll give you. We should have a deep reflection on that because most of us, maybe human, have used to adapt the patient to our technique. So we have technique, we masterize, we learn a lot with the patients, and now we are extending one technique to many patients, to every patient. So maybe I think we should clarify that point on the sense that maybe a 90 years old patient doesn't need to be enucleated because it doesn't care about long-term results. Okay? So a patient with antithrombotic agents, verbal therapies like duocarmine plus I don't know, oral anticoagulants. Do we need to stop the oral antithrombotic agents just because we want to educate the patient? Maybe no, and there is a place, I agree with you, not only with anatomical consideration with the urethra, but the general health status of the patient. So we should not eliminate many options just because we are mastering perfectly enucleation.
And this is why I think we should master other techniques and minimally invasive techniques, either ourselves, like Resume or Urolift, or refer the patient to somebody doing that if we think that the patient needs another treatment, 90 years old or small prostate, or depends. So it's not we're doing enucleation and we're doing this to everybody, but we should adapt to our patient and his needs, of course.
This is the precision medicine.
Any more questions? Okay. Thank you very
Thank
much,
you so much.
Jean-Baptiste. Thank you.